My name is Steve Nyquist, and I am with a company called Salient MD. We work with hospitalist physicians and hospitalist programs across the country, and a particular physician that has assisted greatly in our understanding of how these programs work and what it takes to make them function and function well is Dr. Bob Sheppard. I'm here with him, and we are going to spend a little bit of time today talking about medical director leadership in a hospitalist setting. So with that, I will introduce Dr. Bob Sheppard to you and start, Dr. Sheppard, just by saying broadly, would you say that a medical director changes a program, or would you say that a program changes a medical director?
Good question. I think there's some of both. I had the pleasure, if you will, of starting to be a hospitalist before there was such a thing as a hospitalist. I first had a go at this in the late 1980s rather than the 1990s and 2000, where most people in this hospitalist arena started. We started then at a formal go at it at the University of Alabama in about 2002, 2003. And that gave us the opportunity to sort of start as a groundwork program. It's an academic facility with about a 600-bed regional referral center close by that we worked from. We had 60 medical students, 48 family medicine residents, and as of now, we have about 9 fellowship programs, including one that's a hospitalist program that I'm still the director of. So in those early days, I was able to more tailor the program to what my skill set was, rather than trying to worry about what kind of program I'm working with. There's always that need to be able to blend what the program's needs are together with what the hospital's needs are. And so that in and of itself is a big deal. I think the balance between those two is likely to determine the success of a program in most cases.
So, in a program, we would say, and we've certainly seen it to be true, that all programs are different, sizes are different, expectations of the medical community is different. Are all medical directors different as well, or are there particular attributes about a medical director that would transcend the differences in the program?
There are some characteristics that have to be, I think, on common ground, but no, I think there's more of the individualism present. For me, I'm a leader that is a leader by leading style. I tend to lead people by example more than intimidation. I'm not a confrontational person, and so me telling my partners what to do is not likely the way I'm going to approach it. Just as an example, as we started our program, it wasn't, I would say, a democracy as such. It was more of a benevolent dictatorship. In other words, I did whatever I wanted as long as they were with me, as long as they followed me. If I derailed or I got off on turf that made us uncomfortable, they would pull me back. If I could see them becoming lax in a particular area, I'd be on their case trying to get them to change. But it was more of a pull and tug type relationship where we let need dictate what we did next. We started out, for example, on a 7-on, 7-off work schedule, and we stayed with that for about a month. And then we decided, well, let's try a 4-on, 3-off, 4-on, 3-off, and see if that'll work any better. We did. It didn't. And so we changed it back to 7-on, 7-off. It didn't take very long before a couple of us decided, well, I think I'd like to work 2 weeks on, 2 weeks off. Let's try that. Okay, well, we don't want to do that. Our wives are going to be in our face. You two guys try that and see how it works for you. So we did, worked pretty well, and we did that for about 6 months. And then we gave up and went back to the 7 on, 7 off. So with that one topic, that one idea, we took that approach and tried every iteration of it you could imagine, and kept coming back to the 7 on, 7 off scheduling. And so we decided finally, okay, it is 7 on, 7 off. So, okay, how do you make a schedule out? Well, I made a schedule out for 4 months, 3 to 4 months at a time. In other words, about approximately in quarters of the year. And I would make that schedule out on the calendar, put it out, and that was etched in stone unless two people got together, two of our partners got together and changed that schedule. In other words, if I need to be able to have 9 days in a row off in October, fine, that's okay. But I got to find somebody in the group that's willing to swap out with me so that I could have that time off. That's how we altered that basic 7 on, 7 off schedule. Doing it that way, the schedule just sort of ran itself. Once you put it on paper and put the 7 on, 7 off out there, anybody had the freedom to change it as long as they could get somebody to cover for them when they needed to be off. And only on rare occasions would somebody come to me and say, look, I've asked all 13 partners or all 22 partners, and I can't get anybody to cover for me this time in October. Can you cover it? And then that's when I would step in as a director and try to accommodate.
So it sounds like there's a little bit of, you have an idea of where you want to go, but there's also some listening that involves, and part of it is having the ability to know when to lead by example and when to listen and make adjustments, whether it's schedule or any other topic that would rise.
I think that's exactly right. In other words, I would, if anybody had an idea, we were willing to try it. If it worked, great, we'd take it and run with it. If it didn't, we'd change it back the way we had it.
So let's talk about it's clinical. So there is an aspect of clinical competency that is required, both from how your other providers in the group would see you, just the medical staff would see you, and just the nurses. At what level does clinical competency play into the role of medical director leadership?
Yeah, using today as an example, we had a very unusual program, and that is that we started out with just two of us. So for the first almost 2 years, we worked in a very busy service where I worked 7 on, my partner worked 7 on, and we were opposite each other. So we worked 7 days, 24-hour days, all day and all night, all day and all night, all day and all night. And the only time the other person came in is that if we just got killed, if we got, exhausted and so sleep deprived we couldn't function, then the other person would come in. That didn't happen very often, but it did on rare occasions. So the approach we took was to shoot from the beginning towards trying to recruit more partners. As we did that, my role as a medical director became somewhat really unusual. Instead of buying respect from my partners by working the schedule full time as they did, I took on an even heavier role in that. As we went from 2 of us to 3 of us, we had suddenly an odd schedule, and so we had to go 5, 5, and 5 rather than 7 on, 7 off. We went 5 on, 5 off, 5 on, 5 off, where you work 10 days in a row and then off 5 days, 10 days in a row, off 5 days. But when we got on up to where there was, say, the 9th person came into the group, what we did with that was that I would work 7 on, 7 off for my own spot in the schedule. And then as the director, I worked that other position for the ninth person to make the schedule work out even so that 7 on, 7 off still worked out for everybody else. So I would work many times for months and months at a time until I could recruit the next even person in the group. So go from 8 to 9 and then from 9 to 10. I would work full time, 7 on, 7 on, so to speak, until we could finally get an even number of persons. And then it'd stay that way. I'd be back to 7 on, 7 off till the next odd person came into the partnership. And so that's how we worked it in the early years. And that I always said I want to be the 22nd person in a 23-person group. In other words, when it gets to be 22 of us, I'm going to come out of the schedule and not work. Well, that never happened. It never worked out that way, and I just worked on through for nearly 20 years, just working the schedule as it came up.
Did any of your partners or anyone on the medical staff ever challenge you clinically and challenge you as a doctor, not as a scheduler, not as your willingness to do the work? Obviously, you were there, and so you were the one continuous person that they knew. But as the director, were you ever threatened by somebody thinking you're not a competent physician? And how did you handle that?
Wow, that's a good question. If they ever questioned me as a clinician, they never let me know about it. So I'd never had a question where they questioned what I did as a physician with a given patient. And I worked with all of them. In other words, I picked up from and handed off to everybody in my group from one time to another. So they either just swallowed it or they let it go because they never brought the issue up to me. So I felt like I had a solid level of respect clinically with my whole group.
We've also talked about whether age or maturity matters in just being able to interact with the leaders in the ED at what is an appropriate admission, or when to say this isn't right, a pushback to them, or somebody that would come to you and say, I'm not exactly sure how to handle this. So the question is, does age matter? Does maturity matter in the role of medical director?
Oh, absolutely. I don't think there's any question about that. When I started this program in 2003, I already had 25 years of practice of internal medicine under my belt at that point, and I was obviously an older physician. So all my partners, for the most part, were young physicians, and so sure, even from the beginning, they tended to see me more as a father figure than a partner, and that may well have had some part to take in them not questioning what I was doing.
What about doing procedures? I assume when you started, you did a lot of procedures. In today's practice of hospital medicine, a lot of you have the intensivist programs that have started, and so you have a mix of providers that want to do procedures, don't want to do procedures. How have you handled that over the years?
Yeah, as an older physician in my years in clinical practice, I did everything. I did all the procedures way beyond what the scope of most internists would be. But as time passed, that has changed pretty dramatically. I would say in their first 10 years of our program, it was about half and half. About half of the partners in my group did their own procedures, central lines, bone marrow aspirates, Pearson TCs, Thorson TCs, etc. And I did them, a lot of them, for everybody else because I was again had just done them for a long time. Now that is no longer the case. Now when I get new partners in, rarely do they want to do any procedures. So I would say that precedent has shifted 180 degrees since we started.
Changing gears and talking one question about administration, you obviously have many years of dealing with administration. Would you say the medical director is primarily an advocate for the program to administration or to the program for administration? Surely there are elements of both, but did you see your role as primarily one or the other?
Well, again, I probably had the advantage of not only having 25 years of medical practice under my belt when I started, I also had been a hospital administrator for a decade. So I knew what the administration needed. I knew what their core issues were going to be. So I was able to play that role to a degree pretty easily. But to answer your question, I think the medical director needs to be more of an advocate for the group, but serve well, but communicate well, but deal as a liaison between those two entities with what the needs for both would be solidly in mind.
As far as dealing with other departments, and I'm thinking particularly now of case management or just dealing with nursing staffs and the emergency department, how involved were you in problems or troubleshooting on a daily or weekly, monthly basis?
I didn't have any clerical support people in my group ever in all the years that I was a medical director. I didn't have a nurse practitioner or a clerical person working with me at all. So I took all those phone calls from the group. In the early years, there was not that. There was hardly anything. The case management part of our arena didn't exist at that point in time, and that sort of has developed in the last 10 or 15 years. But yes, I was the one as the director of the program. I was the one who did most of that interaction. And nowadays, however, it is more the individual practitioners one-on-one with the case managers.
So over time, you certainly have seen many different types of providers come to you, and I'm just curious if you've seen any difference of the newer physicians coming out in the world of hospital medicine, and particularly now with the rise of being a locum tenens physician, that there's that level of independence that's one of the joys of being a hospitalist. Give me my patient list, let me go, stay out of my way, I'm going to do it the way I want to do it. And yet there's also something about what is referred to as just the collegiality among the physicians within a group. How have you dealt with the independent physician, and how important has it been to you over time to build collegiality, or is that even important within a group?
Well, it's not only important, it's crucial. But again, I was a little bit protected there because long before I became a part of this program in the hospital where we practice, our hospital locally did not allow us to use locums physicians. Nobody could. No local doctor could recruit anybody and have a locums person cover for them. And that was the case for us. It was the case for even our emergency room. We had to recruit our physicians as full-time, live in the county practitioners, and so we didn't have that luxury of being able to utilize the itinerant physicians that work schedules off and on. For the individual practitioner, as you know, they love it. They like that ability to be able to come and go as they please and work when they want to. And nobody would deny that that's nice to be able to pull those kinds of physicians into the schedule and work when you need them, so to speak. You don't have to commit full time to another salaried position that's going to be requiring a full time position to keep them. That's a trade off. I think you get more collegiality from a group of physicians that all work locally, go to school together, their children interact with each other, their families know each other and eat meals together on a regular basis, etc. I think there is a lot to be said for that, but it's a hard system to put together.
And so to that, if it is important or if it works well for the doctor, and not necessarily even that they have to like each other, and not necessarily that their personalities have to be the same, and they're certainly not clones of each other, but the benefits of being a team, functioning as a team, how did you instill in that over time?
I think that it more happened to me than I generated it or created or engineered it myself. I didn't have that much skill. So I think that collegiality that I enjoyed after many years of doing it came from trying, making mistakes, making everybody mad, having to go back and undo it, having to unlearn what we thought we knew. In other words, trial and error that we did together is what gradually built that collegiality, much more so than anything I was able to figure out in advance and administrate.
You talk about the various members of your team as partners. That's a rare term to be used within members of a program. Why do you talk about them as partners, and are all of them from day one partners?
They are and have been and will remain as full partners from the day they start. And they are true partners in the sense that our pay is not salaried by anybody, but rather is an eat what you kill plan. In other words, we made our incomes was based upon the number of patient encounters that we did for a given time period that was billed for. So we billed, collected the money, and shared equally. When I took on a new partner, that partner made exactly the same pay rate that I made, again, depending on the number of patients they see. So if I saw 25 patients per doctor per day for a 2-week period, and somebody else saw 15, they got a good deal less paid than I did. But on the other hand, if they saw twice as many patients as I did, or worked twice as many shifts as I did, which nobody did. Now, in other words, I never worried about anybody taking my medical director's position because nobody wanted it. It was such an onerous schedule that I had the luxury of doing that on my own with nobody wanting what schedule I worked. But yes, our people were true partners in the sense that they made the same rate of pay from the beginning, and they did not have to buy into the program. They were not salaried. They were based on what number of patient encounters they saw.
And so to talk about bringing in new partners, that involves recruiting. And so when you were recruiting candidates, how transparent were you with those candidates from the time you first started talking to them about their potential compensation, potential schedule, the goods and the bads of the program, administration, the community, et cetera? Were you very open and upfront with them from day one, or did you hold certain things back until you saw that there was interest from their end?
I was very open because I never wanted to recruit somebody and them find out something about the program or about me or one of our partners that they didn't already know. So I would sit down with them from the beginning, from the time they did their first interview, and I had the permission of my group to show each new potential partner exactly who made how much money the previous year, how many shifts they worked, what their schedule looked like, and including my own, so that everything was open. We had quarterly financial meetings where we would have our accountants go over the basic billing information and look to see who made what the collection rates per person and per group look like. so that all that information, we made a big effort to keep it out and open. We had open book policy to all the group.
In when you bring in a partner, you obviously go through a lot of steps to see that they fit to your program, but they all don't fit. How quickly were you able to determine, or were you able to determine, if a new provider, or even one that had been there for a while, it wasn't working out, it just wasn't going well, and how did you determine to either handle it or just part with them?
When I started, I had a lot of experience already at recruiting, so I was able to basically get the information out of a person early on with respect to what their expectations were likely to be. And so with doing that, I would have them come in and start with me one-on-one, and I would just track them from day one. I basically did it this way. I would have a physician see one patient the first day, maybe two, but usually just one. The second day they worked, I'd have them see two or three. The third day they worked, I'd have them see 4 or 5. The fourth day they worked, I'd have them see 6 or 8. And I'd gradually work my way up, typically over about a week to 10 days, to where they were carrying a full load. And then I'd let them carry a full load for another full week. In other words, they'd end up working, say, 3 weeks in a row right when they first start, but ramping them up slowly, and me standing over their shoulder, helping them work through the problems and the issues and learning the medical record system and so forth early on from the start with my one-on-one help. And then at the end of that time, they'd go home for a week and take a week off, and then they'd come back, and from that point on, they carried a full load in the schedule. So that's how we onboarded the individuals from the beginning.
And so surely somewhere in there you would get, whether it's a sixth sense or just feel that there were things that were just weren't clicking with that provider, either with the facility at large or just with your partners. How did you sense, or did you sense, when things weren't working out?
I don't think that ever happened to me during the first 6 months to a year. In other words, I had enough skill at interviewing and onboarding and working with and so forth that I rarely ever dropped the ball in that time frame. But obviously, yes, after a period of 6 months to a year, I had a handful, 3 or 4, over a period of a decade or more, where it became clear that they were unhappy and they were making me unhappy, and that unhappiness was making other partners unhappy. And so what I'd do with those people is I'd sit down and say, look, this is not working out well. I think you are unhappy because of this, and this. Tell me if that's right or wrong. And then once we communicated about what the perceptions were, occasionally I would come to the conclusion that this is not working out for this person. And so I would just simply recommend, look, I'm not firing you. I'm not telling you you have to leave. I'm just telling you, you're making yourself miserable. You're making me miserable. And so let's part this relationship, and you go find a place where you think you can be happy. I'm not mad with you. I don't want you to be mad with me. I'll write you a good recommendation when you leave here, but this is not working well. Either tell me what you think I can do to fix it, or let's part company. So I made it very cut and dried when that kind of issue came to the surface.
One last question. You already talked about schedule. You already talked about your willingness to start 7 off as your program got bigger, and over the more recent years, I assume that younger physicians coming in have a different expectation of wanting flexibility with their time. Have you seen that newer physicians are coming to hospitalist programs different than they did several years ago, or not?
Absolutely. I very much handpicked my people that came to a group comprised of a bunch of people who were hard workers, who were go-getters, who wanted to be able to see a lot of patients. It was not unusual at all for our group to average more than 30 patients per doctor per day. In fact, pushing 40 patients per doctor per day during the early years, the first decade of our practice life. That in today's environment would be like crazy. Nobody can see 35 patients in a day and do a decent job of it. And my contention is yeah, you can. You can't do it in 8 hours. You can't do it in 10 hours. You're going to need 14 to 16 hours to do it. But if you stay there long enough, you can see 30 to 35 patients. Well, I had a group of doctors who wanted it to be that way. They made good incomes doing that. They worked hard. They worked long. They worked a bunch of shifts. And that was just simply the type of individuals they were. No, today, I don't believe you can do that. I think it is much more common to have the patient load be 15 to 18 at best. 15 to 18 patients per doctor per day would be the average in most programs today. And they can do that in 10 to 12 hours and do a decent job of it as well.
Well, Dr. Sheppard, we appreciate your time. We appreciate your wisdom, and thanks for sharing with us. Again, I'm Steve Nyquist with Salient MD. If you happen to look at this and want to ask another question of Dr. Sheppard, feel free to let me know. And thanks for joining us today.